Hi guys, I made this professional practice issue slideshow because I'm finding that's where I'm struggling the most on my practice tests. And for the ANCC, it looks like it's about 32% professional role and responsibility, non-clinical questions. And every time I take one of the practice tests, I'm getting them wrong. So this is for me to help say, see, and learn, and maybe it can help you. Okay, let's see. So the first part of the discussion is ethical principles, and this is all the veracity, which is truth and honesty. Example is reporting known lapses in standard of care. You have justice, which is treating all people the same, no matter what uh, what the backgrounds they have. For example, you have a fixed number of vaccines and you spread them equally, which is a little different than utilitarianism. Utilitarianism. It's a tongue twister. So that's the greatest good for the greatest number of people. So you carefully allocate healthcare resources. So this is different. So if you have given a certain amount of money for vaccines, then you can find a way to make it most cost effective for the greatest good. And beneficence is helping those in need. Example, providing comfort to a dying patient. Non-maleficence is doing no harm to minimize harm. So, for example, you're performing a procedure and harm is pain, but you're doing your best to minimize that. Fidelity is duty to be faithful. For example, a patient will ask you to keep his diagnosis private. That's your duty to them. Autonomy has to do with the patient. So the duty to respect the patient's wishes, their self-determination. If they don't want a blood transfusion, you have to honor their wishes, except if it's putting others in danger. For example, if they have TB and they want to go back into the society, you have to hospitalize them against their autonomy. Telonology, I don't really know even how to pronounce this, but I've seen it on tests. So it's based on the best outcome for the most people, like a smoking ban. And then the next one is a patient-centered model. That is also example of a moral to give up one life to save five. So competency is a little tricky because the law assumes that all people are competent until proven otherwise in a court of law. Competency, you exercise rights to give or refuse informed consent. And the goal is to protect those with impairments while still giving autonomy to others. So with informed consent, the patients must be competent, but also must have the ability to communicate, understand information, and appreciate the consequences. So if their competency is in question, as long as they can verbalize those three attributes, they are still able to give informed consent. And the nurse practitioner must disclose info on all treatment risks and benefits, likelihood of problems, and outcome without the therapy. Presumed consent is in an emergency, life-threatening situation. And in that case, you can perform procedures that would save the life if otherwise not performed. Healthcare proxies make decisions in the absence of the patient's ability to do so. Usually they're designated, but if someone is not dedicated, the spouse is a de facto healthcare proxy. And the 5 wishes directive is how patient wants to be treated at the end of life. It's kind of like a living will. Cultural care is broken into competency, sensitivity, and awareness, which is kind of loosely overlapping. But competency is a culturally sensitive practice related to a patient's beliefs. It's the ability to use academic, experimental, and interpersonal skills to increase one's understanding and appreciation of differences. And cultural sensitivity is knowing the difference, that a difference exists between cultures, but not assigning values to those differences. And cultural awareness is understanding the culture, being open to the idea of changing cultural attitudes. So anyways, it's very similar definitions. An interpreter is a clinician or a hired person who adheres to the National Council on Interpreting in Healthcare. And all patients who are not primary English speakers or don't feel as though they are understanding concepts should be offered an interpreter. Malpractice is the failure to meet accepted standards of care, different than another healthcare provider would do under the same circumstances. Damages must be documented and harm must have occurred, which is different from negligence, which is a deviation from the standard of care. You can have negligence without harm. Assault is putting a person in danger or harm, but contact does not have to occur. I've had a question on that. Battery is the intentional or offensive touching that violates a person's bodily integrity. If a sentinel event is to occur, the policy is to first conduct immediate investigation, report the sentinel event, do RCA, which is a root cause analysis, action plan, present the Joint Commission, the event to the Joint Commission within 45 days, and then monitor outcomes. In the National Practice Database, you might see that, is where all NP malpractice events are stored. So insurance gets a little tricky. There's two types that I've heard discussed: an occurrence base or claims made. Occurrence base is when you are covered no matter what, no matter if your policy is still active. For example, if a year ago I make a mistake in a hospital that I'm covered at, and I've moved hospitals and my insurance is no longer active, the policy will still cover that occurrence as long as it's within the statute of limitations. Claims made, which is the least expensive, is covered only if the incident happens when you're insured and you still have the insurance. So if a year ago I was working at a hospital and an accident occurred and I got sued today, but I'm no longer working there, I would not be covered anymore. You can get a tail coverage if you're in a claims made insurance situation, and the tail coverage will cover you, but that is the most expensive. So Medicare and Medicaid. Medicare is federally funded. There's 4 parts. The way I remember it is Part A is admitted and automatic. So it's people who are 65 years and older or who have end-stage renal disease. And it covers in-hospital occurrences as well as skilled nursing facilities and hospice. Part B, I think of as you broke out of the hospital. So now this is outpatient stuff like durable medical equipment, ambulances, labs, second opinions. And Part C is your choice. So that's inpatient, outpatient, PPOs and HMOs. I believe it's vision and dental as well. And then Part D is for drugs. So those are prescription drugs. Medicaid is for those with low income and disabilities, and that's both federal and state funded. So the Accountability Healthcare Organization, or the ACO, are groups of healthcare providers that come together voluntarily to give coordinated high quality care to Medicare patients they serve. I've had a question on that. And then the Balanced Budget Act comes up a lot in quizzes, and this is what happens. What happened in 1997 that allowed for NPs to bill 85% of their services to Medicare. It must be qualified and legally authorized by the state, and you have to have an NPI number. An NPI number is a 10-digit code that allows an NP to bill. And that NPI number is sort of like your medical social security number, and you just have it for life, no matter which state you move to. All right, billing. I have a really hard time with this. So evaluation and management, or E&M codes, determine the amount of reimbursement you're your services will provide. It's a process by which NP patient encounters translate to CPT codes. In the E&M, you must have history, physical, and a plan. A CPT code provides uniform number for coding for medical procedures, and it's critical to streamlining reporting. So this is an example of a CPT code. It's like 99497 for early discussions of preference about end of life, and 99497 has no limit. And then you have the ICD-10 codes, which classify and diagnose for all claims processing. And that's developed by the World Health Organization. And that's, if you put in R10 dash or period 11, that is coded as right upper quadrant pain. So NP's roles are considered to be building on the competencies of an RN with a greater role and autonomy. You need to be certified, which is voluntary, non-governmental professional organization, like an ANCC. And then you need to have your license, which is provided by the state which you're going to practice. They do a criminal background, work history, and certifications. And then you get credentialed, and that's done by the employee. And it confirms that the NP meets authority regulations, practice authority within the institution, and an NPI number. An NP title is legally protected. It means you've met the requirements in at least one state and licensed to practice as a nurse practitioner. Each state has its own board of nursing. The Nurse Practice Act, each state board of nurses must comply with laws and regulations to maintain their license. And the NP Practice Act is different in each state. The scope of practice looks at your NP Practice Act in each state and encompasses 3 core competencies. And this has come up in a few tests as well. And those are APRN core competencies, role core competencies, and population core competencies. So professional competency involves the 6 sigma, which is quality improvement, a plan characterized by limiting variability and removing deficits or defects in the process. And it involves coaching, which is interpersonal, clinical, and technical skills aimed at assisting the patient and the family to achieve goals for higher levels of wellness. And then you have policy, which is advocacy and understanding of policy and how it impacts ethical, legal, and social factors. And then you have quality, which is evaluation, synthesis, and translation of evidence-based resources. And it's aimed to improve and deliver highest level of care. And you have things like leadership, which is assuming the leadership role in advanced practice and performance of leadership skills. And the ANA Code of Ethics is the who is responsible for the ethical obligation to carry out our responsibilities. So prevention, I think we're pretty comfortable with this, but I feel like the questions on the exam might be a little tricky. So primary is you avoid the problem, secondary is to detect, tertiary is to reduce chronic effects, and quaternary is to identify problems that could be seen as overtreatment, like code. I've had a question about if you are obese and you have and you're exercising, what level of prevention is that? And I think it's secondary because you already have the problem and you are in the process of fixing it. Or it could be tertiary because it's like a rehab service, but this is where it gets tricky. Mostly exercise is considered a primary prevention strategy. The Health and Human Services Treating Tobacco Use and Dependence Guidelines have components for intervention for treating the tobacco use, and those are ask, assist, assess, ask, advise, assess, assist, and arrange. So this is something that came directly from a quiz as well. Ask, assist, assess, no, ask, advise, Assess, assist, arrange. Practice considerations are role modeling, self-management, therapeutic conversations, non-pharmacological interventions, and the American Association of Nurse Practitioners published standards for practice for NPs. And the professional development is performance appraisal and peer reviews. So research ranked from highest to lowest level is systemic review, randomized trials, cohort, case, cross-sectional, and then case reports, and then editorials, expert opinions. Research terms. So the confidence interval is factors that figure into the power of the study, which are results that can be repeated in subsequent studies. Research, power in research is sample size, difference in compliance between groups, size of the expected field. The analysis is to detect effects of the intervention. Stratified is selective reproduction of the population. Non-probability sampling is just picking anyone out of the crowd to reduce bias. Prospective study is observational, like the Framingham Heart Study. The two variables that are measured are the dependent and independent, and dependent is what is measured, that's the outcome. Independent is what determines the dependency. And then you have absolute risk reduction, which is controlled group event rate. Relative risk is the percentage of baseline risk. And relative risk possibility is the probability of exposed versus non-exposed group. So some terms for epidemiology are false positive, is test is positive, but they don't have it. False negative is a test is negative, but they do have it. Sensitivity and specificity get me a little confused. So I had seen this as a trick to remember. It is sen is seen, you do have it, and specificity is SP out, spout, you do not have it. Prevalence is a number of individuals who have an illness at a given time. Incidence is the number of new cases. The validity of a test is the accuracy. And you have both internal and external. Internal, if it's in question, that means there might be some research design flaw, and external can be replicated out in society. You can use the validity to reproduce the event in your practice. Reliability, consistency, and measurement. Null hypothesis is what you're trying to disprove. You have two types of errors. Type 1, null is rejected and it's true. Or type 2, null is not rejected and it's false. Alternative hypotheses are what you're trying to prove. And the p-value is a significant result when it's less than 0.05. There's a number of acts that I'm trying to remember as well, and that's the Affordable Care Act, which is Obamacare. Deficit Reduction Act is the deficit of care aimed to reduce Medicare fraud. So for example, if you have a hospital-acquired infection, this also falls under the Deficit Reduction Act. You will not get reimbursed by Medicare if your patient does acquire a Hep B or hospital-acquired infection. The Omnibus Reconciliation Act is to protect elderly against acts such as restraint without cause in long-term care facilities. And then you might see it as Consolidated Omnibus Reconciliation Act, which is COBRA, and that's the right to continued health benefits, even if you're out of work. And then you have the Balanced Budget Act, which helps balance the budget by allowing NPs to bill for their service. And the Health and Human Services developed regulations for HIPAA, yet the Office of Civil Rights are the ones that enforce the protections safeguarded by HIPAA. Okay, and then you have all the health models. And this is not all of them, but ones that I've seen come up over and over again. And the health belief model is that patients will make positive health changes if they're threatened by a condition, like perceived threat, or if you actually have a threat, like if they have an MI, and they then will eat healthier. And then you'll have the trans theoretical model of change, which is also seen as TTM. And then it has 5 stages. It's pre-contemplation, contemplation, preparation, action, maintenance, and termination or relapse. Those kind of make sense if you march down the scale. And then you have the PCOT formula to formulate evidence-based practice. And then that helps you formulate proper questions to study, and it's population, intervention, comparison, outcome, and the type of study. And then the synergy model is resilience, vulnerability, and stability. That's all I could come up with for this presentation to help myself and hopefully you. Hope it helps. Good luck.